Welcome everyone. Please note we will be recording the session and would appreciate if you could share the recording afterwards with your associates, your colleagues, teams, partner services, social media, friends and family. After the webinar, a new harm reduction video will follow. Comments are off, but please contact me afterwards with any questions. If we all work together, we can reduce the number of deaths from overdose. Thank you. Thank you for joining this REACH webinar. It is International Overdose Day on the 31st of August 2025. REACH Drug and Alcohol Services are running a campaign to raise awareness around the topic of opiate overdose. Today's agenda is an information section about what are opiates and what is the data, a recognition section, who is likely to overdose and what does an overdose look like, and a prevention section, what to do if someone is overdosing and what do REACH offer. What are opiates? Opioid versus opiate. Opiates and opioids are used medically. Both are prescribed for pain relief, anesthesia, cough suppression, diarrhea suppression, and treatment of opioid use disorder. The main difference is how opioids and opiates are made. Opioids are chemical compounds that generally are not derived from natural plant matter. Most opioids are made in the lab or synthesized. Examples of well-known opioids are loperamide, hydrocodone, oxycodone, methadone, fentanyl, and carfentanil. Opiates are chemical compounds that are extracted or refined from natural plant matter, poppy sap, and fibers. Examples of opiates are opium, morphine, codeine, and heroin. Opium, a dried latex derived from the seed capsules of the opium poppy, Papaver somniferum. It contains alkaloids, including morphine, which is a powerful painkiller. Morphine is a strong painkiller, for example, after an operation or a serious injury, or pain from cancer or a heart attack. Morphine is available only on prescription. It comes as tablets, capsules, granules that you dissolve in water, a liquid to swallow, or an injection. Morphine injections are usually only done in hospital. Morphine can be chemically processed to produce other opioids, like heroin. Codeine is a painkiller, for example, after an operation or an injury. It is also used for ongoing pain when painkillers such as paracetamol, ibuprofen, and aspirin have not worked. Codeine is also used to treat diarrhea. It works in the central nervous system and the brain to block pain signals to the rest of the body. It also reduces the anxiety and stress caused by pain. Heroin is a powerful opiate that's usually sold as a white or brown powder. Heroin is classified as a Class A drug in the UK under the Misuse of Drugs Act 1971. This means it is illegal to produce, sell, or possess heroin. Whether a person is using prescription opioids or illegal opiates, they both have the same effects and risks. Nitazines are new opioids which have arrived in the UK in the last 2 years. They have recently been found mixed with heroin, with some being sold as illicit oxycodone pills or even Xanax powders. Nitazines can be at least as strong as fentanyl and can be hundreds of times more potent than heroin. They are known to have led to accidental overdoses and deaths of people in several areas across the UK recently. The vast majority of people taking drugs do not expect to die from an overdose. And there's a chart which shows the relative potency to heroin. As you can see, fentanyl is 50 times more potent, but etonitazine is 500 times more potent. A bit of history. Opium, the poppy plant, was cultivated in Persia, Egypt, and Mesopotamia 3,500 to 5,000 years ago. There's some evidence that Neanderthal man may have used the opium poppy 30,000 years ago. The first known written reference to the poppy appears in a Sumerian text dated from around 6,000 years ago. As an aside, the flower was known as Hul-gil, or plant of joy. The only culture without an indigenous psychoactive substance appears to have been the Inuit. Reasons for this are environmental. Their climate is unsuitable for survival of psychoactive plants or animals, for example, toads. A bit about academic views of psychoactive substance use. Psychologists see it as abnormal, forensic, or criminal, for example. Sociologists see it as deviant or a subculture. Pharmacologists focus on physical and mental harms caused by drugs. And criminology sees drug use and crime as co-occurring. The alteration of consciousness is a normal behaviour. It is one of the basic drives or needs along with sex and food, etc. In humans, this is achieved by several means, for example, fasting or dancing or meditating. But the quickest and most effective route is by ingestion of a substance, usually toxic. How many people go to the pub, smoke, drink coffee, or take paracetamol when feeling unwell? And on the alteration of consciousness, animals appear to alter their consciousness via a range of substances as well. You can read R.K. Siegel's Intoxication, the Universal Drive for Mind-Altering Substances, or G. Sammarini, Animals and Psychedelics. Endogenous DMT is a very powerful Class A psychedelic drug and is present in all animals at all times. And you can read R. Strassman, DMT, the spirit molecule. All of us here have receptors for opiates present in our brains. So the alteration of consciousness, why do people do it? Well, it's for enjoyment, relaxation, sociability, self-exploration, and pain relief, including psychological pain relief. The big question is, why do some people become addicts and others don't? There is a self-medication hypothesis. Clients use substances to reduce psychiatric symptoms, but substance use as a form of self-medication can turn into addiction. Clients may have a genetic predisposition. They may have learned about becoming an addict in a social setting. Patterns of use have an influence on whether somebody becomes addicted, whether their use is stable or chaotic, occasional or habitual, whether they use a little or use a lot. There may be social factors at play. A person may have little in the way of social capital, education issues, literacy issues. They may have legal income generation opportunities which are limited. A lot of substance misuse may be happening around them. It's probably chaotic or problematic. They're possibly injecting as a method of use. There's possible generational exposure and cycles of deprivation. It depends on the intent behind the use, whether it's enjoyment or self-medication, for example. And it's about whether the person is socially and psychologically integrated. We need to understand the communal ritual aspects of use and educate how to use, when not to use, risk reduction, etc. There is also the matter of drug, set and setting. Again, understanding the communal ritual aspects of use and knowing when to stop. On drug set and setting, a person's potential for becoming addicted is affected by this. The drug is the pharmacological action of the substance. SET is the underlying and learned psychological aspects of the user, also biological factors. It's the mindset of the user. Setting is the situational factors and the wider social and cultural context, the external setting. And you can see from the graphic there is an interplay with these three areas. Regarding the mind, many problematic drug users also have other mental health problems such as depression. There could be many underlying health problems. They could be exacerbated by problematic drug use, and they may be the result of long-term problematic drug use. There is strong and increasing evidence that many problematic drug users are seriously traumatized. And there are two references there if you want. People will begin using drugs and alcohol after trauma up to 76% of the time. This is an interesting experiment leading to some questions around how setting affects substance use.
You get a rat and you put it in a cage and you give it 2 water bottles. One is just water and the other is water laced with either heroin or cocaine. If you do that, the rat will almost always prefer the drugged water and almost always kill itself quite quickly. In the 70s, Professor Alexander noticed we're putting the rat in an empty cage. It's got nothing to do except use these drugs. Let's try something a bit different. So Professor Alexander built a cage that he called Rat Park, which is basically heaven for rats. They've got loads of cheese, they've got loads of coloured balls, they've got loads of tunnels. Crucially, they've got loads of friends, and they've got both the water bottles, the normal water and the drugged water. But here's the fascinating thing. In Rat Park, they don't like the drugged water. They almost never use it. None of them ever use it compulsively. None of them ever overdose. You go from almost 100% overdose when they're isolated to 0% overdose when they have happy and connected lives. You get a rat and you put it in a cage.
Sorry. Next we have some data in black and white. Statistics in England and Wales. The age standardised mortality rate for deaths related to drug poisoning has risen every year since 2012. 4,907 deaths related to drug poisoning were registered in 2022 and 5,448 deaths in 2023. Males was 127.6 per million in 2023 and females was 59.8 deaths per million. Of the deaths registered in 2023, 3,618 were identified as drug misuse, accounting for 61.8 deaths per million people. Rates of drug misuse deaths continue to be elevated among those born in the 1970s, often referred to as Generation X, with the highest rate in those aged 40 to 49 years. Just under half of all drug poisoning deaths registered in 23 were confirmed to involve an opiate. That's 46.8%. That's 2,551 deaths. There were some with cocaine, but there was a 30.5% more than 2022 and represents the 12th consecutive. Globally, by age 50, roughly 50% of opioid users will have died, most commonly by overdose. The harms from overdose extend beyond mortality. For every fatal overdose, it is estimated that there are 25 to 50 near misses. Apart from the immediate harm from near misses, e.g. anoxic brain damage or injury through fall, a history of non-fatal overdose is a significant predictor of subsequent overdose and of subsequent fatal overdose. The Southwestern Ambulance Service kindly provided some data. It relates to ambulance attendances occurring within the Dorset County area, including Bournemouth, Christchurch and Poole, in the 6-month period, the 1st of January to the 30th of June 2025, where the ambulance clinician has recorded a diagnosis relating to drug overdose or recorded the administration of naloxone in an electronic patient clinical record. Drug overdose incidents can relate to both intentional and accidental drug overdose involving both illicit substances and prescription medication. 286 patients were attended for drug overdose in the 6-month period. 171 of these were administered naloxone and admitted to hospital. 28 of these were administered naloxone and not admitted to hospital. Figure 1 shows the frequency of drug overdose attendances by age group and gender. As you can see, the highest numbers are in the age range of 35 to 49. Again, that's Generation X. Figure 2 is a heat map showing the frequency of overdose attendances by postcode district in Dorset in this period. Red is higher, yellow is lower. These show that the highest number of attendances in Dorset were BH1, DT4, BH8 and BH2. Who is likely to overdose? Risk factors for opioid overdose include having a disorder of opioid use, taking opioids by injection, resumption of opioid use following abstinence, for example, detoxification, release from prison, cessation of treatment, using prescription opioids without medical supervision, high prescribed dosage of opioids, for example, more than 100 milligrams of morphine or an equivalent daily, combining opioids with substances that suppress respiratory function, such as benzodiazepines, barbiturates, anesthetics, or some pain medications, and having concurrent medical conditions such as HIV, liver or lung diseases, or mental health conditions. Males, people of older age, and people with low socioeconomic status are at a higher risk of opioid overdose than women. People of young age groups and people with higher socioeconomic status. What does an overdose look like? These are the signs. So to recognise an overdose, it would show slow or stop breathing and heart rate, cold or clammy skin, body is weak or limp, vomiting, unresponsiveness or unconsciousness, pinpoint pupils, snoring or gurgling sounds coming from the mouth, blue lips or fingernails. There are some similarities, so it's hard to spot the difference between being really high and overdose. Really high is nodding off, overdose is deep snoring or gurgling. Really high is sleepy looking, overdose is very slow breathing or not breathing. Really high is will wake up and respond to shouting or being shaken, and overdose is not responsive to any stimulation, including rubbing the signs of overdose are listed again there. What is an overdose? Opioid overdoses happen when there are so many opioids or a combination of opioids and other drugs in the body that the victim is not responsive to stimulation and or breathing is inadequate. This happens because opioids fit into specific receptors that also affect breathing. If someone cannot breathe or is not breathing enough, the oxygen levels in the blood decrease and the lips and fingers turn blue. This is called cyanosis. This oxygen starvation eventually stops other vital organs like the heart, then the brain. This leads to unconsciousness, coma, and then death. Within 3 to 5 minutes without oxygen, brain damage starts to occur, soon followed by death. With opioid overdoses, surviving or dying wholly depends on breathing. This process is rarely, which usually happens minutes to hours after the drug was used. While people have been found dead with a needle in their arm, more often there is time to intervene between when an overdose starts and before a victim dies. Overdose does not necessarily mention what to do if someone is overdosed. Call 999, follow their instructions, administer naloxone, do rescue breathing if they're not breathing, lift the chin and open the airway, give 2 slow breaths to make the chest rise, turn your head to check the chest is rising. If the chest is not rising, tilt the head more. Breathe again every 5 seconds. Continue until they are breathing or services arrive. Put the person into recovery position if you need to leave the scene. What can REACH offer? So we are considering new information around contaminated drugs, and the way drugs are used needs to change to avoid overdose. Mixing drugs is more likely to cause an overdose, so it's best to use one at a time. If drugs are going to be mixed, use less of each. Drugs should not be used alone. The signs of overdose need to be watched out for. Always carry naloxone. It's available from all treatment providers, including REACH. If someone overdoses, give naloxone to them and call an ambulance. Naloxone only works on opioids. However, if it is suspected that someone has overdosed, they can be given naloxone even if it is not certain they have taken an opioid. It will not harm the person. If someone uses opioids every day, their local drug treatment service, for example REACH, can support them and prescribe alternatives such as methadone and buprenorphine. Even if a person is not trying to achieve abstinence, prescribed alternatives can help keep them safe. They will know what they're taking and their risk of overdose may be reduced. If a person is already in treatment for opioid dependence and they don't want to use on top, they can speak to their worker and make sure they're getting the right dose. REACH offer nitazene testing to clients. I will be sending a harm reduction video out to you all soon, and I would appreciate if you could send it out to other providers. Thank you. What is naloxone? Well, it's medicine that reverses an opioid overdose, an opioid antagonist. It attaches to opioid receptors and reverses and blocks the effects of other opioids. Naloxone can restore normal breathing to a person if their breathing has slowed or stopped because of an opioid overdose. But naloxone has no effect on somebody who does not have opioids in their system, and it is not a treatment for opioid use disorder. Naloxone can be given as a nasal spray, or it can be injected into the muscle, under the skin, or into the veins. You can give naloxone to someone who has overdosed. Families of people with opioid addictions should have naloxone nearby. Ask their family member to carry it, and let friends know where it is. People should still call 999 immediately in the event of an overdose. And lastly, what do REACH offer?
REACH is open to anyone over 18 living in North, East and West Dorset. We also have services for young people aged up to 18 with a transition phase from 18 to 25 led by the adult service. REACH has 3 hubs in Wimborne, Weymouth and Gillingham, providing easy access to clients within our catchment area. When a referral is made, we do an initial assessment and risk assessment to inform a personal tailored care plan. Our client will initially be offered a person-centered treatment program of up to 12 weeks of intensive support. They will have an individual recovery navigator who will work alongside them and other services to ensure goals around substance reduction and abstinence are fully supported. For more complex or intensive requirements, the support will continue until the client is ready to be discharged. We have opiate substitution prescribing nurses and alcohol detox nurse who support both community and residential detoxes. We offer harm reduction advice, free naloxone, free needle exchange and free blood tests for blood-borne viruses, including hepatitis, as part of the Dorset-wide Hep C microelimination programme. Our clients will have access to free 24/7 digital support, employment specialists, preventing homelessness, specialist family support including around social services, criminal justice team, health improvement and mental health treatment requirement team. We offer one-to-one and structured group sessions using motivational interviewing and active listening skills to create positive change. At the end of 12 weeks, our client's case is reviewed and support can be extended, but the desired outcome is our client is now stabilised, at which point we offer aftercare for a further 12 weeks. This is when the level of reach intervention is reduced to support our client's newly felt independence. If the levels of risk or vulnerability increase at any time, our client can re-present with a single phone call or a referral back into the service. Another episode can be opened on their case file and work can begin again, reviewing their care plan and goals. Reach currently help around 4 new people daily to manage their substance use, offer 95 brief interventions per week to keep our clients on track, assist 388 people weekly with clinical interventions including prescribing and health checks, support 2 people daily in achieving their recovery goals and moving forward. Reach work from a trauma-informed model and our approach is person-centred. Reach genuinely care. It's easy to make a referral for someone you're working with or yourself.
Thank you very much. Please feel free to email me. Bye.